of the National Institute of Dental and Craniofacial Research. But beyond that, frankly, she is the human that made it possible for me to start a bone health clinic at Children's in DC, and I couldn't have done it without her. So this is a special moment for me. Let me introduce and welcome Rachel Gafni. Thanks, Rach.
Thanks, Laura, for that really lovely introduction. I'm going to share my screen, but just be aware, I work for the government, so titles are kind of all you get. So don't be too impressed by that long name of the institute that I work in. That's just your usual government stuff. So can everybody see my screen and hear me okay? Yeah,
sounds good. Thank you.
Okay, good. All right, so I see there's a lot of people on the call and a lot of friends, which is exciting. I wish I could see everybody in person because it's been a long 2 years with not having in-person meetings. Let's see, it's not advancing. Here are my disclosures. I will be discussing some work that we are doing in collaboration with calcilytics in clinical trials in autosomal dominant hypocalcemia, as well as discussing some non-FDA approved treatments. So let's just take it back to 1849 to Sir Richard Owen, who was a zoologist and anatomist in England, who dissected a rhinoceros and identified a new gland, Owen's gland, which it took him quite a while to publish, 1862. But then in a few years later, Ivar Sandström, who was a medical student in Sweden, also identified this gland in other small animals, cats and dogs. And this is, of course, the gland that we now know as the parathyroid gland, which was really the last identified anatomic structure to my understanding. And PTH, we all know, is incredibly important. It's very important for the tight regulation of blood calcium. And PTH, working through the calcium sensing receptor, maintains blood calcium by acting on these different organs. Excuse me. Sorry, going the wrong way. PTH release stimulates osteoclastic bone resorption to release calcium into the blood. It stimulates renal calcium reabsorption, and it also stimulates the production of active vitamin D in the kidney to act at the gut to absorb calcium through the diet. Specifically, PTH acts at the kidney in different locations. In the proximal convoluted tubule, it increases urinary phosphate, so it is a phosphaturic hormone, and it's also the proximal tubule where it facilitates calcitriol production by stimulating 1-alpha hydroxylase. Meanwhile, in the distal tubule in the thick ascending limb is where urine calcium reabsorption occurs. Now, PTH secretion is regulated by the calcium sensing receptor. And when calcium is around and activates the receptor, this inhibits the release of parathyroid hormone. And conversely, the circulating blood calcium level is low, PTH release is increased. We also have calcium sensing receptors throughout the kidney, throughout the nephron. And similarly, when these receptors are activated by calcium, renal calcium excretion is increased. So basically, the kidney is being told that there's plenty of calcium around, so it doesn't need to be reabsorbed into the bloodstream. It can be excreted into the urine. And these are ways to prevent hypercalcemia and also maintain normal blood calcium levels. So in patients who have inadequate parathyroid hormone levels, they experience hypocalcemia, hyperphosphatemia, because they can't excrete phosphate in the urine. Many, but not all, have hypermagnesemia as well. And they typically have inappropriately normal or frankly elevated urine calcium, despite being hypocalcemic. Hypocalcemia leads to neuromuscular irritability, including seizures and laryngospasm, twitching, tingling, cramps. Patients can have basal ganglia calcifications. And in the skeleton, because PTH is important for bone resorption, patients who are hypoparathyroid have decreased bone turnover, and this leads to increased bone mass in adults. Patients can also have other calcifications such as cataracts. And one very common complaint in patients with hypoparathyroidism is a decreased quality of life, specifically describing brain fog, fatigue, depression, difficulty in focus. And then there's also treatment-related complications associated with conventional therapy, which is further worsening of the hypercalciuria, which can lead to nephrocalcinosis, nephrolithiasis, and even renal insufficiency. Now, the most common cause of hypoparathyroidism is postsurgical hypoparathyroidism occurring after a neck surgery, typically a thyroid surgery, but sometimes parathyroid surgery as well. And the incidence is variable, but really if you go to high volume centers, it's quite low, less than 2%. So when you have a patient who needs a thyroid surgery, finding the most experienced thyroid surgeon is important to prevent hypoparathyroidism. Approximately 75% of patients with postsurgical hypoparathyroidism have just a transient form and it resolves, but about 25% are permanent. And you can see on these graphs, you can see these 4 different lines looking at postoperative PTH levels. And the postoperative PTH levels, particularly within the first week after surgery, do appear to be somewhat predictive of predicting the likelihood of it becoming permanent. And we generally consider it permanent if they're still hypoparathyroid after a year. Now, I'm a pediatrician, so most of the patients I see do not have postsurgical hypoparathyroidism. They have a genetic form of hypoparathyroidism. And believe it or not, this table doesn't even include all of the genetic forms. I have another table that has them all, but it really started to get too small for a slide. So these are some of the more common rare ones, and I like to divide them into 3 groups. The top section is disorders of parathyroid gland formation. The middle group are disorders of parathyroid gland secretion, and this includes magnesium disorders because magnesium is important for PTH secretion. And then at the bottom are disorders of parathyroid gland destruction, including, of course, neck surgery, but also infiltrative diseases and autoimmune diseases that destroy the parathyroids or act in other ways to inhibit parathyroid function. So probably the most common genetic cause of hypoparathyroidism is its association with the 22q11.2 deletion syndrome, which we all remember as DIGeorge syndrome or Velocardiofacial syndrome, and it has several other names. But now we know that it's a spectrum disorder due to a contiguous gene deletion at this locus. Patients have it, and it's quite common. It's in about 1 in 2 to 4,000 live births. About half are hypocalcemic, but the hypocalcemia can wax and wane, and it can appear later in life as well, so you shouldn't rule it out. And there's a whole sort of associated features with this syndrome, including cardiac, dysmorphic facies, thymic hypoplasia, cleft palate, and then a lot of cognitive issues. Psychosis is actually quite associated with it, schizophrenia, swallowing dysfunction, there's a whole list. One of the more common isolated genetic forms of hypoparathyroidism is autosomal dominant hypocalcemia, or ADH. And this is usually due to pathogenic activating variants in the calcium sensing receptor, which alters the set point for parathyroid hormone release. So in this case, when the receptor is activated, the parathyroid gland is sensing that the calcium level is higher than it in fact is, and thus PTH release is inappropriately suppressed. ADH2 is due to a downstream mutation in GQ11, one of the G proteins, and results in pretty much the same thing, where PTH release is inappropriately suppressed in the face of hypocalcemia. And of course, because the calcium receptor is located throughout the kidney, patients with ADH who have activating mutations also have inappropriately elevated urinary calcium excretion, which is often even much higher than patients with other forms of hypoparathyroidism. Another important group on that table is autoimmune hypoparathyroidism, which can present in adults and can be isolated or associated with other autoimmune diseases and is a polygenic disorder. So There's not a specific gene that we know that causes this. But as pediatricians, we typically think of APSED, autoimmune polyendocrinopathy candidiasis ectodermal dystrophy syndrome, which is also known as APS1 or autoimmune polyglandular syndrome type 1. This is an autosomal recessive disorder due to inactivating variants on the ARI gene. And ARI stimulates expression of peripheral tissue antigens in the thymic medullary epithelial cells, so it promotes tolerance. So when you have a deficiency of this, you have increased autoimmunity. And there are a couple of autoantibodies that are highly sensitive and specific for APSED, but to my knowledge, they are not commercially available. And we typically think of the classic triad with APSED: hypoparathyroidism, adrenal insufficiency, and chronic mucocutaneous candidiasis. But you can see from this series at NIH that there are many, many features that sometimes we don't even think about. In particular, I'd like to draw your attention to the skin nail urticarial eruption, which is actually present in quite a high percentage and often is typically presents before age 20, but often will present in young children and may present before the onset of hypoparathyrodism. So if you have a child with chronic mucocutaneous candidiasis who also is having recurrent hives, you might want to consider this in the differential. And of course, intestinal dysfunction is a very important component of this disorder. Here's a patient with some of the skin and nail features: alopecia universalis, vitiligo, and nail dystrophy. And what's nice is that when you are suspecting a genetic cause of hypoparathyrodism, there currently is a free genetic testing program for patients with non-postsurgical hypoparathyroidism. I put the website here, and I believe this will be recorded. And these are the genes that are tested. It's a very, very comprehensive list. I'm not sure how long this program will be available, but I encourage you, if you have patients in whom you suspect a genetic cause, that they get this done. It's important for genetic counseling, as well as perhaps looking for other associated comorbidities in syndromes, and also may affect the way you treat the patient. So you have your patient with hypoparathyroidism. How do you manage them? Well, and I'm not putting a lot of specific doses because there's pediatric population attendees as well as adult attendees, so it's highly variable. But generally, we want to give calcium in divided doses throughout the day. We use vitamin D metabolites, calcitriol or alpha-calcidol, which are the active forms of vitamin D, because remember, PTH is necessary to convert 25-hydroxyvitamin D to 1,25-dihydroxyvitamin D. But you can use high doses of ergo or cholecalciferol, and we'll talk a little bit about that in one of the cases that's going to be presented later. Some patients also need magnesium supplementation, and you'll often see talk about using thiazide diuretics in significant hypercalciuria, which does promote the distal tubular reabsorption of calcium, and it's not been systematically studied in hypoparathyroidism. And an important disclaimer I should make straight up about this chronic management is a lot of what I'm going to talk about is what I do or what's expert opinion, but it's really critical to realize that in the literature, there are not a lot of randomized controlled studies looking at different ways of conventional therapy. There's a lot of expert opinion, and this is how I do it, and this is why I do it, but not really rigorous studies looking at different regimens with conventional therapy. Now, when you're putting patients on calcium, and you're talking to patients and asking them how much they take, it's really important to know what they're talking about, because some calcium supplements are labeled as a salt and some are labeled as elemental calcium. So for example, a patient might tell you that they take 1,000 milligrams of calcium, but they might be talking about Tums Ultra, which is only 400 milligrams of elemental calcium, because calcium carbonate is 40% elemental calcium. So you always need to have the patients flip over the bottle and read the label carefully, because it might not be just that you're looking at the the milligrams in the salt as opposed to the elemental. But you can see in the bottom, it's giving you, for example, this calcium citrate. It says there's 630 milligrams of calcium per serving, but a serving is 2 caplets. So it's only 315 milligrams per tablet. So make sure you read the label carefully, and you're always talking about elemental calcium. The goals of conventional therapy are to target the serum total calcium to the low normal range, sometimes even slightly below the lower limit of normal, particularly if they're very hypercalciuric. In patients, it can be hard to completely normalize the phosphate, but if you can get it into the high normal range, that's good. Getting the magnesium into the low normal range. And keep in mind that symptoms of hypomagnesemia are very similar to symptoms of hypocalcemia. You do want to try to avoid hypercalciuria, which is defined as 4 milligrams per kilo per day, greater than 4 milligrams per kilo per day, or greater than 0.1 millimoles per kilo per day, and avoiding an elevated calcium and phosphate product, because this may increase the risk for ectopic calcium deposits. I typically monitor patients' laboratories every 3 months. Even if they're on very stable doses, I check them every 3 months. And the reason I do that is because if I wait 6 months and they come back with a high calcium of 10 milligrams per deciliter, I don't know if that's been going on for a month or for 5 months. And I would rather check them every 3 months to make sure that they're not really having hypercalcemia or above their target range for a prolonged period of time. I check a 24-hour urine collection for calcium and also citrate and other analytes at least yearly, as well as doing a periodic renal ultrasound. And it's important to realize, we showed several years ago that ultrasound is actually more sensitive than CT for detecting early nephrocalcinosis. You can see in the first column, these are beautiful, normal looking kidneys with no calcium deposits, and you see these beautiful black triangles in the ultrasound. But in grade 1 nephrocalcinosis, you're already starting to see calcifications around the pyramid, but you can barely see it in the CT. There's a little arrow there pointing. You can start to see it in the CT a little bit in grade 2, but the patient really has to have pretty significant nephrocalcinosis to be able to see it in the CT. So you're going to miss it if you're just doing CTs. Plus, that's more expensive and it's more radiation. So ultrasound is a better way to go. Other things that I tend to recommend to my patients, which again, not really well studied, but I encourage them to reduce their salt intake, and which is healthy for everybody because it's important for blood pressure as well. But sodium and calcium are co-transported in the kidneys. So when patients tend to consume a lot of salt, oftentimes that will be reflected with a higher urinary calcium. I don't specifically restrict their phosphate intake, but I do encourage them to limit excessive consumption of high phosphorus foods and eating meat in moderation as well. And then of course, because of the hypercalciuria, it's important that the patients drink a lot of water to prevent renal calcifications. So you're constantly walking this treatment tightrope where on the one hand, you want to keep the blood calcium high enough so that they're not having symptoms, yet you also need to keep the urine calcium down. So what about giving them parathyroid hormone? And this is the intact parathyroid molecule. It's 84 amino acids with the biological activity in the first 34 amino acids. And as such, there's 2 types of parathyroid molecules that have been used to treat disease. One is PTH 1 to 34, the active fragment or teriparatide. And then there's intact full-length PTH 1 to 84. And so this isn't really a new concept. Back in the 1920s in Canada, Dr. Cullip, who was also involved in the first development of insulin for diabetes, had this dog here who was in tetany after a thyroparathyroidectomy, and he gave him an injection of parathyroid extract. And now you see this puppy perked right up 3 hours after the injection and looks great. But this is now almost 100 years ago. So the first question is, could we use parathyroid hormone therapy to manage the hypocalcemia of hypoparathyroidism? And will it also ameliorate the hypercalciuria seen with conventional therapy? And there are many, many, many studies looking using PTH 1 to 84 and PTH 1 to 34 in patients with hypoparathyroidism. But I'm just going to mention, in the interest of time, this one study that did lead to the FDA approval for PTH 1 to 84 for hypoparathyroidism. This was the REPLACE study that had 134 subjects. 75% of them were post-surgical. None of them had autosomal dominant hypocalcemia. And this was a 6-month treatment period, and they were randomized 2-to-1 to receive PTH or placebo. And the primary endpoint was a 50% reduction in calcitriol and calcium supplements. So they're not trying to do full hormone replacement therapy, just reduce their pill burden. And 53% of the patients achieved the primary endpoint, and 43% were able to stop calcitriol completely. And here's the data, and it's presented a little bit in a little bit of an unusual fashion. The top panel are the placebo patients, and the bottom panel are the PTH treated patients. The open symbols are the blood calcium, and the closed symbols are the urine calcium. So just to summarize, the serum calcium decreased initially in the placebo group and increased in the PTH group. So that makes sense because the PTH group was still on supplements and getting PTH as well. And the urine calcium decreased in the placebo group, which makes sense because the blood calcium was going down, but essentially didn't really change in the PTH group. So it was still a little bit high. And also not shown here, the blood phosphate decrease, which is an important endpoint as well. Now, and that led to the approval of PTH 1 to 84 by the FDA. And then these patients, 49 of these patients now went into a 5-year open label extension called the RACE study. And this is their blood and urine calcium over that 5-year period. And as you can see in the top panel, the blood calcium was very nicely maintained on this PTH 1 to 84 for 5 years, really staying within the target range of 8 to 9 milligrams per deciliter. And the urine calcium did come down somewhat, but still was staying a little bit high. And actually 68% of the patients had hypercalciuria at baseline, and 45% still had hypercalciuria at 60 months. So it really didn't fully ameliorate the hypercalciuria. So this is just a little bit of the timeline that we talked about. In the late 1800s, the parathyroids were identified. In 1925, it was given to a dog. And then there was more research and more studies. And then finally in 2015, PTH injections were approved for hypoparathyroidism, but unfortunately 4 years later, it was recalled due to rubber contamination. But of course, what I showed you in the data was even that approval of that PTH 1 to 84 in 2015, it clearly wasn't a perfect drug or a perfect regimen because it did not consistently decrease urinary calcium excretion. And one question you might ask is, could it even increase renal morbidity? And could it have an adverse effect on the kidneys? So we did a study with PTH 1 to 34, treating 31 patients twice daily with full replacement on no calcitriol for up to 5 years, and looked at some of their urinary indices. And we did see a statistically significant decrease in urine calcium while they were on PTH. But what we saw importantly was a marked drop in urinary citrate. And citrate in the urine is important to prevent renal calcifications. It helps avoid crystallization by the calcium that's in the urine. And when we looked at the effect of the PTH dose on these analytes, the PTH dose did not correlate with the degree of calcium excretion in the patients, but the higher the PTH dose, the lower the urine citrate dropped. And when we looked at renal imaging in these 31 patients, we were pretty upset at what we saw. We had six of the patients had no nephrocalcinosis at baseline, and they didn't change throughout. There were 8 patients who had stable nephrocalcinosis or nephrolithiasis, and that also didn't change during the study. But 16 of the patients, 52%, either developed new or worsening nephrocalcinosis and nephrolithiasis while on PTH 1 to 34. And this is an ultrasound of one of the patients at baseline who was a 40-year-old man with a calcium sensing receptor mutation who had a normal renal ultrasound. And after 1 year of PTH 1 to 34, you can see that now he has nephrocalcinosis. So another question is, how does intermittent PTH therapy affect the skeleton in patients with hypoparathyroidism? And we can see here from these studies with PTH 1 to 84 that the bone turnover increases very significantly with intermittent PTH injections, which is not surprising because remember, hypoparathyroidism is a low bone turnover state. But what's a little bit concerning is that the bone turnover markers are still quite elevated 6 years into treatment. And we see this very significant increase in bone density in the lumbar spine, femoral neck, and total hip, and a dramatic decrease in bone density in the radius with PTH therapy. And if you look at iliac crest bone biopsies, you'll see increased trabecular bone with tunneling, an increased bone formation rate, increased mineralizing surface, and increased cortical porosity. And this new skeletal state is being maintained for quite a while. So you're really seeing this sort of mixed anabolic and catabolic effect where maybe the trabecular bone might be going up, but the cortical bone is going down. And these are just some biopsies from our PTH 1 to 34 study, where you can see the normal trabecular bone is green here and marrow is orange, and the cortical bone at the bottom. And after 1 year of PTH 1 to 34, you can see the trabecular bone is thicker and has this tunneling showed by the arrows. But now the cortical bone is kind of full of holes. It's become more porous. And this kind of makes sense because you're giving PTH in these injections, in these intermittent injections, not in a physiologic way. And this is the normal endogenous PTH secretion pattern. And keep in mind, this is in picomoles per liter, and the normal range is 1.5 to 7 picomoles per liter. And for some reason, this graph starts at 2 p.m. and you can see the slight increase in PTH that occurs in the middle of the night. But it's pretty tight. There is a little bit of this diurnal variation. In contrast, when you give somebody with hypoparathyroidism an injection of PTH 1 to 84, shown here by the dark circles, you see this rapid, tremendous increase in PTH levels up to about 4 times the upper limit of normal. That's about 28. And as you can see, maybe the upper limit of normal is about 7 picomoles per liter. And the PTH level is staying abnormally elevated for many, many hours before coming back down into the normal range and becoming undetectable again. So this is clearly giving intermittent injections of PTH doesn't appear to be physiologic. So what about giving a continuous subcutaneous PTH using, for example, an insulin pump? And there are several case reports doing that. I'll just show you one report out of the NIH that looked specifically at children. This was a short study. It was a randomized crossover trial with 3 months per arm, and it was 12 children, mostly teenagers. 5 had APESED and 7 had activating variants of the calcium sensing receptor. And they were being compared to twice daily injections versus pump. And you can see that the blood calcium in panel A, the blood calcium was a little bit higher in the patients treated with pump. And in panel B, the urine calcium appeared to be lower, but that did not, in the pump patients, but that did not reach statistical significance. But the bone turnover markers were not as increased in the patients on pump therapy. And so that suggests that continuous infusions might be more physiologic. I just did want to point out that it says in the abstract that the pump delivery normalized mean urinary calcium excretion, but as I mentioned, those were not statistically different. So just to do a brief summary of what we know about using PTH 1 to 34 and 1 to 84 in hypoparathyroidism from a whole gamish of studies, which I can't obviously show them all. But PTH therapy can really effectively manage hypocalcemia, but the effects on hypercalciuria are variable. PTH 1 to 34 induces a marked hypocitraturia, which has the potential to increase renal morbidity. PTH therapy increases bone turnover and cortical porosity, and the effects on bone are variable. It appears to be anabolic in trabecular bone and catabolic in cortical bone. I didn't show you, but discontinuation of PTH therapy is associated with hungry bone syndrome. And when we took our patients who were treated with PTH 1 to 34 off, it often required significant doses of calcium and calcitriol for many months before they were back down to their baseline to avoid hypocalcemia. Continuous PTH therapy may be more physiologic. And I also didn't show this data, but there are some studies to suggest that PTH therapy may improve quality of life, but it's a little bit hard to tell. And in some of the placebo-controlled trials, it's not really 100%. So clearly we need more research, more therapies, new directions, and I'm not going to discuss all of these on the list. Certainly long-term prospective studies using PTH pump therapy would be important, looking at long-acting PTH analogs, other PTH receptor modulators, PTHRP, and allosteric modulators of the calcium sensing receptor. So I'm just going to mention two studies, two products that are under investigation right now. One is TransCon PTH. This was first presented in JBMR in 2020 in their phase 1 study. And this is a long-acting PTH 1 to 34 that is bound to a proprietary TransCon linker and a carrier. And when the drug is injected, it's gradually released depending on changes in pH and temperature. So it's as opposed to seeing this big surge in PTH after you give the injection, it's more gradually released. And then the carrier and the linker are excreted through the kidneys as the PTH 1 to 34 acts with the PTH receptor. Recently, the phase 2 study was published. So this was a 4-week placebo-controlled trial followed by a 22-week open label extension. And this data in this study in this figure is presenting 49 adults who were followed to 26 weeks. And again, it's important to note that none of the patients in this study had autosomal dominant hypocalcemia. But the results in these other forms of hypoparathyroidism were quite good. 92% of the patients had normal blood calcium on the TransCon PTH, and 84% had normal urine calcium. So this is a little bit better than what was shown in the RACE study. 100% of the patients were off calcitriol and 94% were off calcium. And there was also some data to suggest improvement in quality of life measures. So this seems very promising. What about bone turnover? There were, as expected, increases in bone turnover markers. There's bone formation, with this P1NP on the left, and bone resorption, which is CTX on the right. And in both cases, TransCon PTH increased these bone turnover markers, although to a lesser extent than was seen with the PTH 1 to 84. So time will tell, this was a short study, what the long-term effects on bone will be with this drug as well. So the next steps for this drug, they're currently conducting a phase 3 study, which does include ADH patients. And as a pediatrician, of course, I always have my fingers crossed for pediatric trials. There had been a black box warning for PTH previously because of concerns of osteosarcoma due to animal data, but this hasn't really been borne out in humans who have been receiving PTH for osteoporosis for years and years and years. And the black box warning was removed in November of 2020. So I don't know if that will improve the likelihood of pediatric trials. But the important thing to remember when we think about all these genetic forms of hypoparathyroidism is that PTH therapy will still not affect the calcium sensing receptor in the kidney and will not help to the same extent patients with ADH1 who have an altered set point for calcium in the kidney. So really better treatments for ADH1 are needed. And I'm going to tell you a little bit about one of the studies we're doing at the NIH using a drug called encaleret. This is an investigational oral calcilytic, and calcilytics are negative allosteric modulators of the calcium sensing receptor. So they they bind to a site different from the ligand binding site of the receptor, and they decrease the sensitivity of the calcium sensing receptor to extracellular calcium. So this is trying to now shift. So remember, in ADH1, the set point is abnormally shifted. The cell thinks that the calcium level is higher than it actually is. And when you give this negative allosteric modulator, you reset the receptor to a more appropriate sensing level. So normalizing calcium sensing receptor sensitivity could correct the hypocalcemia, hypercalciuria, and low PTH that we see in individuals with ADH1. This is the current study we have ongoing at NIH. It is a 3-period study followed by a long-term extension. We presented the results of period 1 at Endocrine Society in 2021. The results of period 2 were presented at ASBMR in October of 2021, and I'll be presenting that again now, and we're looking forward to presenting the results from period 3 at the Endocrine Society meeting in 2022. So these are the baseline characteristics of our study population. We have 13 patients enrolled. 8 of them were women, and there were 9 unique calcium sensing receptor variants shown at the bottom, listed at the bottom there. The patients had a baseline calcium of about 8 with a very low PTH of 2.8, an elevated phosphate of 5.1, and many of them had normal magnesium, some were a little bit low, but low normal magnesium, and elevated 24-hour urine calcium, and they were on pretty typical supplemental calcium and calcitriol doses. And we can see here during period 2, which was a 5-day inpatient stay where their doses were individually titrated, the blood calcium rose over the course of those 5 days from quite low to being into the normal range, and urine calcium pretty much immediately dropped into the normal range after the first day of receiving this calcilytic. PTH levels also rose into the normal range, and you can see at baseline, you can see it's below the normal range, but almost immediately with just the first dose, the PTH levels rose. So the parathyroid glands were sort of raring to go. As soon as they saw this drug, they started to make PTH, and blood phosphate levels also declined on the drug. So to summarize, hypoparathyroidism is a disorder of inadequate circulating PTH leading to hypocalcemia, hyperphosphatemia, and inadequate renal calcium reabsorption. It may be caused by a variety of acquired and genetic disorders. Conventional therapy with calcium and vitamin D analogs do not address the pathophysiology of PTH deficiency and may exacerbate hypercalciuria. And ongoing investigations with PTH analogs and allosteric modulators of the calcium sensing receptor demonstrate the potential for better treatments. I want to let everybody know that this series of papers hopefully will be published in the next several months. This is being submitted this week. This was a summary statement and guidelines from the 2nd International Workshop on Hypoparathyroidism. I was very pleased to be a part of it. There were 50 international experts, and these papers address the prevention, diagnosis, and management of hypoparathyroidism and gives both expert-based guidance and as well as evidence-based recommendations. Some of the findings were presented at ASBMR 2021, and I hope you all look for those series of papers. I'd like to thank everybody in my group at the NIH who has worked on a lot of these PTH studies with us, as well as our outside collaborators. And now I don't know if we're taking questions or just going straight to cases, but I will stop sharing.
Thank you, Rachel. That was terrific. You already are